Welcome to the education session presented by the APSA Outcomes and Evidence-Based Practice Committee. Today's session will discuss surgical management of ulcerative colitis in children and adolescents. We have no disclosures. The questions that were aimed to be addressed by this review included: what is the optimal reconstruction for pediatric and adolescent patients after proctocolectomy for ulcerative colitis? What is the optimal timing for elective reconstructive surgery? Is there a benefit or disadvantage to minimally invasive procedures for ulcerative colitis? When should diversion be considered at the time of small bowel anal anastomosis? And what are the rates of infertility and sexual dysfunction following proctocolectomy and reconstruction? Several databases were searched with the help of a reference librarian. Various keywords were used depending on the question. Inclusive dates were 2008 to 2019, and we restricted the search to English language articles only. 1,078 initial abstracts were obtained. 92 titles were found to be duplicates. 986 abstracts were reviewed by the entire team. 183 manuscripts were chosen for further full review, and for each question, 2 members of the team were assigned to full review of the articles in question. A final tally of 88 manuscripts were eventually included in the review. Question 1, what is the optimal reconstruction for pediatric and adolescent patients after proctocolectomy for ulcerative colitis? This question focused on reconstruction anatomy rather than surgical techniques. 7 studies were selected for final inclusion. They contained a mix of pediatric and adult patients. They assessed variable outcomes such as early or late complications, as well as stool habits. Also, variable disease processes were included, including Crohn's and FAP. There were no prospective or randomized controlled trials and lots of long-term survey data. There was some evidence for a higher number of daily stools and more soiling with straight ilioanal anastomoses as opposed to pouch reconstruction. Level of evidence ranged from 3 to 5, and we are unable to make any definitive recommendations to answer this question.
Our second question was, what is the optimal timing for elective reconstructive surgery for ulcerative colitis? Optimal timing is important as we balance the risk of medical and surgical management, and we wanted to discuss when the timing of surgery should occur for initial subtotal colectomy or during the interval timing between subtotal colectomy and restorative pouch. Historically, this is done when maximal medical therapy has been reached. Similarly, for the optimal interval between restorative proctocolectomy following subtotal colectomy, that's really patient specific. No studies simply ask that, no studies answer those questions. However, Gray found that the PUCI index may be beneficial for determining the appropriate surgical management. These authors evaluated 60 patients and found that those individuals who had a lower PUCI uniformly underwent a combined or 2-stage procedure. The authors noted that the cutoff score of 45 was more commonly found in a 2-stage procedure, while scores greater than 45 were more commonly found in a 3-stage procedure. The ultimate decision, however, for deciding a 2-stage versus a 3-stage procedure, they felt were dependent upon the surgeon and the clinical decision-making based upon the patient in front of them. 15 manuscripts were then evaluated for discussing further timing of surgery. 3 were excluded due to lack of relevance, and 3 additional manuscripts were added as we did our manuscript review. Rialon and others suggested that pouch creation should be deferred until adolescence. They evaluated 25 children who had a diagnosis of indeterminate or ulcerative colitis at the age of 5.4 years. 21 of these children were ultimately included in the study because of these findings. Of these children, 5 were ultimately reclassified to Crohn's disease at a median age of 13.4 years. And thus they discussed that we should wait till adolescence because of the chance of having a a new diagnosis that would affect long-term outcomes. However, they did not evaluate any long-term outcomes in their patients. Several studies have evaluated the outcomes of surgery when performed in pediatric patients. Fennell and others found that over time, surgery is being performed at a later age in children. They looked at a 20-year period and found that during the second 10-year period of this study, that the age of surgery was 11.4 years versus 8 years. They did not discuss what the underlying reason was for that. Bismar et al. Found that surgery in young patients, considered 5 to 12 years, when compared to older patients considered 13 to 18 years, showed no difference in their functional outcomes, and that these children could be operated on safely at a younger age. Several manuscripts have discussed concerning surgery between pediatric patients and the adult patients with ulcerative colitis. Probably the largest study to date is Wu, which compared 104 pediatric patients with 1,135 adult patients. The average age at reconstruction for these pediatric patients was 13 years. While they noted that pediatric patients did have a higher rate of pouch-related complications and some hospital-related issues, the long-term pouch retention rate was similar in both groups, as well as long-term function. 2 further retrospective studies showed no difference in long-term functional outcomes between the children who underwent pouch creation and others, and adults who also underwent pouch creation, suggesting that operating on children at a younger age, again, is safe. Steroid use is common in many of our pediatric patients with ulcerative colitis, even as we are moving into other immunosuppressants. Most of the articles that looked at steroid use ranged from 2011 to 2015. 2 of the articles by Uchida and Marco both looked at specific complication rates from steroids and found that both of these patient populations did have an increased risk of complications when on steroids. Interestingly, though, Uchida also evaluated whether or not operating on these children at an early age, despite the complication risk, would affect them in a beneficial way. He found that these children actually started having catch-up growth earlier than other children if they were operated on at a younger age. And so while steroids are known to have risk factors for wound healing and other complications, we must weigh the benefits of continuing the steroids versus the benefits of operating on these children at a younger age to allow them to have the steroids removed and continue on with other medical management. The majority of studies that were out there evaluated the risk associated with other immunosuppressant medications that have come in the last decade and become more popular in the pediatric patients. 2 studies found no increased risk of postoperative complications, including pouch failure or anastomotic leak in children who were receiving calcineurin inhibitors, infliximab, or thiopurines. 4 studies specifically evaluated the role of infliximab alone. 1 study in 2011 looked at infliximab within 8 weeks of surgery, and they did note that there was an increased risk of postoperative complications. However, this was only statistically significant in small bowel obstructions, and other children did not have any issues with these from a complication rate, including abscess or pouch leakage. 3 studies showed no further differences when infliximab was provided within 8 weeks of surgery. Infliximab does not seem to increase the risk of surgical site infections or other infectious complications, suggesting that it is safe within the perioperative time period. 1 study looked specifically at vedolizumab, which has been FDA approved over the last several years for the treatment of ulcerative colitis. They looked at 13 pediatric patients when provided vedolizumab within 12 weeks of surgery. None of these patients developed any postoperative infectious complications, and all of the children did well. So while timing of surgery is important to mitigate complications from ongoing medical management, we need to discuss the other risks that could come up from surgical management. The PUCI index may be beneficial in determining the appropriate number of stages based upon the score that is provided. Waiting until adolescence, especially in very young patients, may be appropriate, especially if there is a diagnostic concern. But when performing surgery at a young age, it does not seem to increase the risk of long-term complications or adversely affect our long-term functional outcomes of the pouch. Steroids do have an increased risk of surgical complications, but early surgical therapy may benefit these children by allowing them to wean off the steroids quicker and allow them catch-up growth. Immunosuppressants, aside from the steroids as mentioned, do not seem to increase the risk of postoperative complications or adversely affect long-term functions of the pouch. The level of evidence for these articles is 3 to 4, and the grade of recommendation is a D.
The third question addressed by this review is there a benefit or disadvantage to minimally invasive procedures for ulcerative colitis? There are 20 studies that pertain to this topic. They all had variable methodology as well as variable outcomes that were studied. There were no randomized controlled trials or prospective studies. There were 19 retrospective studies that were included in our review and 1 case series that was excluded. 3 of these studies used Nisquip peds. In 11 studies, there was a mix of adult and pediatric patients, and generally the number of pediatric patients and outcomes for the pediatric subgroup were not discernible based on the text. All of these studies focused on different outcomes. Those studies that pertain to fertility are going to be discussed in question 5. In terms of operative and short-term outcomes, the complication rates were similar or lower in the laparoscopic group when compared to the open group. There was a longer length of OR time with the laparoscopic approach that was seen in 2 studies. 4 studies showed a shorter length of stay with the laparoscopic approach, and on average, this was approximately 2 days shorter. In 2 studies, there was a shorter time to initiation of oral feedings. In 2 studies, there was a shorter interval to ileostomy closure when used with the laparoscopic approach. 2 studies did show a higher rate of postoperative small bowel obstruction in the open group when compared to the laparoscopic group. However, all these studies had a variability in the difference in overall complication rates, and they were not consistent across studies. In terms of long-term outcomes, specifically continence, there were 3 studies that had variable length of follow-up, and there was no difference between the laparoscopic and open group that was found in continence, soiling, or need for medications. So in summary, there's a suggestion that overall laparoscopy leads to a shorter length of stay, shorter time to PO intake, and shorter time to ileostomy closure, if applicable, without an increase in complication rate. Laparoscopy can be considered as a surgical approach to pediatric patients with ulcerative colitis. The evidence here is level 3 to 4, and this results in a grade D recommendation.
Our 4th question evaluated when should diversion be considered at the time of a small bowel anal anastomosis. Ileostomy is routinely be considered at the time of pelvic anastomosis for protection by diverting the fecal stream and allowing for a decrease in complications if there's an associated leak from the anastomosis. However, ileostomies do carry their own risks, including poor wound healing and surgical complications such as peristomal hernia, prolapse, and bowel obstruction, both during the time of surgery as well as during the ileostomy takedown. The question arises then whether ileostomy should be performed routinely at the time of an ileal pouch anal anastomosis or other reconstructive proctocolectomy. 9 studies were initially identified for this question. 3 were excluded initially due to a lack of relevance, and 1 was subsequently added for a discussion of vedolizumab specifically. A total of 7 studies were therefore reviewed. These studies were mostly retrospective in nature. 2 studies included retrospective data from a single institution review. A total of 133 patients were included between these 2 studies. They noted that there was no long-term functional difference in pouch outcomes between those who were diverted and those who were not diverted. Patients, interestingly, who underwent an ileostomy were at an increased risk for small bowel anastomotic leak and surgical site infections during the ileostomy closures, thus questioning whether an ileostomy actually increases the rate of complications. They felt that performing a reconstructive pouch without a diverting ileostomy may be appropriate in select patients. 1 study specifically looked at long-term outcomes in patients with ulcerative colitis, including pediatric and adult patients. This was done using surveys, and 134 patients in the Danish National Registry were queried. They found that the majority of patients did well. However, 10% of the patients did have an inferior quality of life due to pouchitis or pouch failure. They noted that the ileostomy rate was decreased during the latter part of the study as more procedures were being done without diversion. However, they did find that diverting ileostomy was not associated with these pouch failure rate or quality of life issues, again supporting the thought that ileostomy in a select group of individuals may be safe to perform. The most recent study was a 2019 multi-institutional review. 37 patients were included, of which 17 patients were had a reconstructive proctocolectomy were performed without diversion. These undiverted patients had a longer length of stay and did have more anastomotic leaks. However, when you look at the long-term follow-up, that was approximately 2.5 years, this did not translate into any change in functional outcomes. Two studies looked specifically at the ileostomy complications. The vedolizumab study that was mentioned previously did show that there was an increased risk of mucocutaneous separation in these patients at the ileostomy site. The other study looked at BMI and azathioprine and found that children with a high BMI or who were on azathioprine in the immediate perioperative period did have a higher complication rate of peristomal hernia, prolapse, and stoma retraction. The last study that was included was a consensus panel by the European Society of Pediatric Gastroenterologists, Hepatologists, and Nutrition. They provided guidelines from 2011. These were 19 experts who looked at 17 questions. Under the question of, is there a preferred surgery in children, there is 100% consensus amongst the 19 people on the panel. The recommendation was for a pouch creation versus a straight pull-through, and they felt, in addition to this recommendation, that a restorative proctocolectomy without protecting ileostomy could be considered in select children, especially those who were not on steroids or who had a well-done surgery without any complications. In summary, our recommendations are that a restorative proctocolectomy without diverting ileostomy can be considered at the surgeon's discretion in the appropriate patient setting. Creation of stomas may be associated with an additional risk for complications, especially in certain patient populations. This is a level of evidence 3 to 4 with a greater recommendation of a D.
Our last question that we looked at was question number 5. What are the rates of sexual dysfunction and infertility following proctocolectomy and reconstruction? Rates of infertility and sexual dysfunction have been evaluated in the adult population. Fertility and sexual dysfunction in patients with ulcerative colitis who have undergone proctocolectomy is an important topic, as pediatric providers may not remember to address these topics when discussing expectations following surgical management of ulcerative colitis. Women may have difficulty becoming pregnant, carrying to term, and having a vaginal delivery. Rates of infertility have been shown to be increased following IPAA, as high as 63% in a meta-analysis. Both males and females may have alteration in sexual function as a result of surgery. A total of 36 studies were selected following full text review. Of these, 11 studies were excluded, 9 for a lack of inclusion of patients with ulcerative colitis and/or mention of a proctocolectomy/surgical approach, 1 for lack of relevance, and 1 for containing duplicate data. Thus, 25 studies were utilized for the analysis. These studies contained a mix of surgical reconstruction types, variable outcomes within and across studies. The studies also contain variable inflammatory disease processes such as Crohn's disease and FAP. Finally, there was no prospective or randomized control trials, and a large number of the studies contained survey data. We sought to determine the effect of surgical proctocolectomy for ulcerative colitis on female and male infertility and selected 11 manuscripts. Issues answering this question from the selected literature included a variable definition of infertility. Specifically, studies utilized heterogeneous definitions of infertility, such as inability to become pregnant after 12 months of unprotected intercourse, number of live births, success of in vitro fertilization, or included women who were married or cohabitating and were of childbearing age, regardless of whether they were trying to conceive. There were lack of comparison groups, mixed groups of patients, including those with Crohn's and FAP, difficulty in establishing timing of surgery in relation to conception, differences in surgical technique and number of surgeries. Often the surgical approach was unknown, and finally, the fertility status was often unknown prior to conception attempt. Review of the 11 articles demonstrated a range of infertility from 30 to 65%. For surgical approach, laparoscopy was associated with less infertility versus open. Timing of surgery was not related to ability to give a live birth. Approximately 30% of women with ulcerative colitis following surgery utilized assisted reproductive technology. ART did not decrease the chance of live birth, and a success rate was similar to that of the general population when utilized. Ileal pouch anal anastomosis leads to reduction in birth rates for females, but potentially an increased rate for males. 20% of males and females were childless by choice, and delivery with cesarean section was more likely. Specifically looking at the rates of sexual dysfunction following proctocolectomy and reconstruction, sexual dysfunction in inflammatory bowel disease ulcerative colitis encompasses a multifactorial etiology, namely abdominal pelvic reconstructive surgery, disease activity, hormonal changes, age-related factor, and medication effects. The majority of studies used validated surveys to measure sexual dysfunction in males and females with ulcerative colitis, and a surgical history included utilizing the International Index of Erectile Dysfunction, and the next one was Female Sexual Function Index, or FSFI. Studies demonstrated that having inflammatory bowel disease was not associated with sexual dysfunction. Changes in sexual function did not improve sexual satisfaction. And following IPAA creation, male scores for sexual dysfunction improved while female scores did not, or improved at greater than 12 months following surgery. Pouch failure was not associated with female-male sexual function. Female sexual function related to post-surgical leakage. There was no difference in hand-sewn versus stapled anastomosis. There were no differences for limited versus total mesorectal excision. And surgical complications such as pouchitis, stool frequency, were not significantly correlated with sexual satisfaction. To answer this question, the effect of surgical therapy, specifically proctocolectomy for ulcerative colitis, on female infertility is uncertain. It is also uncertain if there are differences in infertility among those undergoing open versus laparoscopic procedures. Previous surgery was associated with higher risk of miscarriage, use of assisted reproductive technology, cesarean section delivery. These findings are based on very low quality evidence. As a result, definite conclusions cannot be made, and future well-designed studies are needed to fully understand the impact of surgery on infertility and pregnancy outcomes. Sexual dysfunction is not correlated with surgical technique during restorative proctocolectomy, and pouch failure was not associated with female-male sexual function. Given the low levels of evidence, we cannot give any conclusive recommendations. In summary, for question 1, what is the optimal reconstruction for pediatric and adolescent patients with proctocolectomy for ulcerative colitis? We have insufficient evidence to make any recommendations. For question number 2, what is the optimal timing for elective reconstructive surgery for ulcerative colitis? Surgery can be safely performed in pediatric patients. Perioperative immunosuppressants does not seem to increase long-term failure, and timing of surgery should be individualized to the patient. For question 3, is there a benefit or disadvantage to minimally invasive procedures for ulcerative colitis? Laparoscopic surgery can be an option for pediatric patients and may be associated with shorter length of stay and an earlier time to oral intake. For question number 4, when should diversion be considered at the time of small bowel anal anastomosis? When restorative proctocolectomy can be performed in select patients without diverting protective ileostomy. And finally, for question number 5, what are the rates of infertility and sexual dysfunction following proctocolectomy and reconstruction? The effect of surgery for ulcerative colitis on female infertility is uncertain, and sexual dysfunction did not seem to be related to surgical technique or the presence of surgical complications or pouch failure. Thank you.
Hello, my name is Mehul Raval, and on behalf of the APSA Quality and Safety Committee, we would like to present some tools on how to implement best practices that you've just heard about from the Outcomes Committee in terms of enhanced recovery principles for children undergoing gastrointestinal surgery. Let's begin by talking about the origins of the principle of enhanced recovery. The idea here is relatively simple. We know that surgery is controlled trauma and stress for our patients. After surgery, all patients have a decrease in function and take some time to return to their baseline or maybe even into an improved state. The idea of enhanced recovery is really simple in that what we want to do is decrease the amount of time that it takes for our patients to recover and get back to baseline. And this is not a novel concept. This is something that Heinrich Kellick, pictured here, has been talking about for over 20 plus years. In 1999, he published his initial series of sigmoid colon resections in adult patients, where he was able to get them home after a length of stay of only 2 days. 20 years later, we are still trying to implement and emulate many of the principles that he described. There are many components to an enhanced recovery protocol, and no one individual element is really that complicated. What's really challenging is putting together the bundles of care that allow us to take care of patients prior to admission in the preoperative setting, intraoperatively, and postoperatively, and making sure that each of these elements is indeed done and done right. The pre-admission period includes things like making sure that we have educated our patients and their families about what to expect. The preoperative phase includes things like decreasing our fasting protocols so that kids can be drinking a high carbohydrate drink right up until the time of surgery, or at least 2 hours before surgery. We try to avoid use of opioids. We try to teach them some things such as mindfulness or deep breathing exercises. In the intraoperative phase, we do things like limit the amount of IV fluids we're giving our patients. We try to avoid the use of tubes and drains and employ the most minimally invasive surgical approaches that we can. We also try to adhere to all the surgical site infection prevention bundles that we know can help our patients recover. In the postoperative setting, we want to do things like remove any drains or catheters as early as possible, advance their diet, and decrease the amount of IV fluids they're getting. Once again, we try to avoid postoperative opioids while still maintaining adequate pain control. And we really want to make sure that our patients and their families are engaged in the process and are advocating to be able to move forward. There's a tremendous amount of evidence supporting the use of enhanced recovery protocols in the adult world. There's been over 13 randomized controlled trials, hundreds of publications. There's an Enhanced Recovery After Surgery Society that has annual meetings that I would strongly encourage folks that are interested to attend. If you take a look at all of this literature, what you see is that enhanced recovery really results in a 2 to 3 day reduction in length of stay, a decrease in the rate of complications that patients face, with no increases observed in readmissions. Now, enhanced recovery protocols have been developed mostly for adult colorectal and gastrointestinal surgery, but also span things like gastrectomy, GYN oncologic surgery, pancreatic surgery, liver surgery, and so on. And when we look at enhanced recovery in the world of pediatric literature, what you see here is an exponential rise in the number of papers that are being published each and every year addressing this topic. And just to give you a brief glimpse, there are now enhanced recovery protocols that have been published related to bariatric surgery or pectus repairs, same-day discharge for cholecystectomy and appendectomy. For our pediatric orthopedic and neurosurgeons, there are now spine protocols for enhanced recovery. In urology, there are enhanced recovery protocols for hypospadias and complex bladder reconstructions. And even for the plastics, ENT, and OMFS population, there are enhanced recovery protocols for cleft repair. So let me briefly tell you about one pilot study within the world of pediatric gastrointestinal surgery. This is work that was led by Dr. Kurt Heiss, Heather Short, and myself out of Atlanta a few years ago. Here are our pilot study results. We had about 40 patients in our pre-implementation of enhanced recovery time period and about 40 patients in the post period as well. The vast majority of these patients underwent major abdominal and gastrointestinal surgeries like ileocecectomies, partial colectomies, total colectomies, J-pouch creations, and so on. The majority, 80 to 90% of these patients were patients with inflammatory bowel disease. And we know that this is a major problem with about 70 to 100,000 children currently living with inflammatory bowel disease in the United States. And we know that about 15% of these patients undergo surgery within the first 5 years of diagnosis. Here are our results with time along the x-axis. The y-axis on screen left represents the number of enhanced recovery elements that we were implementing. The box plots represent that. And as you can see, as we transition from 2014 to 2015, we see a jump in the number of elements that were being utilized. At the same time, with the y-axis on the right side of the screen in the blue line, what you see is a decrease in our length of stay from about 5 to 6 days to about 2 to 3 days. Here are some of the other outcomes of interest that we were able to study. The top left panel demonstrates, once again, length of stay in the blue line, but also a decrease in the number and the amount of intraoperative fluids being utilized, going from about 10 milliliters per kilo per hour down to about 4 milliliters per kilo per hour. The top right panel shows a decrease in the utilization of intraoperative opioids, which almost went down to 0. Similarly, the bottom left panel shows postoperative in-hospital opioids going down to almost 0. And our length of time until they are tolerating a regular diet was essentially 1 day after implementation. So what do we conclude from this pilot study? We're able to see that enhanced recovery protocols in children undergoing GI surgery is feasible, it's safe. We expect shorter lengths of stay with the protocol and less opioid utilization with no real increases in complications or readmissions. This is a more long-term follow-up of that same study. Once again, you see the blue line indicating the average length of stay did indeed level out at about 3 days, with the number of elements sustaining in the double digits. We also followed up our outpatient opioid prescribing practices related to the enhanced recovery protocol. And what you can see is that prior to implementation, somewhere between 60 to 85% of our patients were going home with a prescription for opioids, versus in the post-implementation period, we were able to decrease that number down to about 20 or 30% of patients going home with prescription opioids. This is another similar article that was recently published by Dr. Phillips and the group at UNC Chapel Hill, looking at their implementation of an enhanced recovery protocol for pediatric colorectal surgery. Once again, the majority of their patients were indeed patients with inflammatory bowel disease. What they were able to clearly demonstrate were, once again, decreases in the opioid utilization, decreases in time until oral intake, decreases in the time that patients had Foley catheters in place. They showed a trend towards decreasing complications and length of stay as well. They measured it in hours rather than days, but nonetheless, a decrease in the length of stay. There's one final paper I'd like to highlight. This is by Dr. Jellin and Dr. George and the team at Hopkins. They looked at how process measures facilitate their success of their enhanced recovery protocols. So they looked at adherence to the protocol. Once again, 40 to 80% of their patients were IBD patients. They had 4 cohorts that they were comparing: pre-implementation, early implementation, late implementation, and those that did not enroll in the enhanced recovery protocol. There was indeed a learning curve to enhanced recovery implementation. And what they saw is that their outcomes improved as their compliance with the protocol improved. Specifically, the late implementation cohort had the best outcomes. One of the things that we can take away from this body of work that is emerging and growing in our field is that we have a lot of nuts and bolts to implementation and successful implementation. And these are tools that are things like patient-facing materials for education or order sets and things along those lines to really empower our patients and their families. And so next, I'm going to turn the talk over to Dr. Phillips from UNC Chapel Hill, who is going to discuss what is available to you as APSA members on our APSA Quality and Safety Toolkit. Thank you for your time.
My name is Michael Phillips. I'm an assistant professor at the University of North Carolina, and I'll be walking you through the APSA Quality and Safety Committee Toolkit for enhanced recovery after surgery, with a specific focus on GI surgery. As Dr. Raval said, enhanced recovery after surgery is a protocolized approach to pre-op, intra-op, and post-op management of common surgical conditions. Within the toolkit, you'll find a master contact list. You'll find instructions for starting your own ERAS pathways at your institution, as well as instructions for submitting those pathways to the Quality and Safety Toolkit to share the lessons learned from your institution with your colleagues around the country and the world. These toolkits include protocols as well as presentations, patient and provider education, and published data from the implementation of these ERAS pathways in pediatric surgery. The website is found here on this Google site. It is it can also be found by searching for APSA QSC Toolkit, and I've bookmarked mine so I can find it quickly. When you land on the homepage, you'll see the ERAS folder here highlighted in red. When you select that, it takes you to an additional landing page, and as this becomes more developed, we will reorganize this with additional information. Right now, you then select QI projects, and when you land here, you see a number of different things within the Google Drive. The first is a master list of other surgeons who've implemented these pathways and uploaded their pathway guidelines to the toolkit. In case you have questions as you read through their pathways, you'll know who to contact. There are also helpful resources for pathway development, as well as instructions for submitting your pathway once you've developed it and implemented it at your institution. To review the recent literature, that we keep a folder that is updated quarterly with new studies in quality improvement for enhanced recovery after surgery for children. You can see within this toolkit, there are pathways from the Children's Hospital of Philadelphia for colorectal surgery. Dr. Heiss has uploaded the Children's Hospital of Atlanta enhanced recovery pathway. The Children's Hospital of Philadelphia has uploaded their ERAS pathway for post-op Wilms tumor patients. Denver Children's has uploaded their enhanced recovery pathway, and Pittsburgh has uploaded their enhanced recovery pathway for complex abdominal surgery, as well as laparoscopic cholecystectomy. Sunrise Children's in Nevada has uploaded their pathway for pediatric abdominal surgery, and we'll spend a few minutes exploring the UNC ERAS folder just to give folks a better idea of what they'll find. On entering the pathway folders, there'll be a read first document, and ours has a brief description of the procedure, the description of the protocol, who the stakeholders were in pathway development and implementation, as well as challenges and solutions and results of pathway implementation. When you click on the pathway itself, you'll see that we have ours organized by phases of care, including pre-op, pre-op day of surgery, and intra-op management. And then on the reverse side, we have the post-op care of these patients, as well as discharge instructions. This allows folks to get a sense of what exactly is being done to improve care at different institutions, and gives you a starting point so that not all of us are having to reinvent the wheel at each of our own institutions. I'm happy to share the work of the Quality and Safety Committee, but want to recognize that this is work done by the individuals who've uploaded their pathways, and ask that folks who are interested in sharing their pathways, feel free to upload them on your own or email me, and I'm happy to upload them for you or answer any questions you have about the toolkit or enhanced recovery pathways. Thank you very much for your time.
Great. Well, we hope you enjoyed that session. A lot of phenomenal content in terms of the literature review, as well as a lot of resources out there available to our APSA members through the Quality Institute implementation of enhanced recovery. And so we're very happy to take any questions, and we'll keep an eye on the chat box and spend some time together. And in the meantime, I do have a couple of questions that we could begin discussing as we wait for things to show up into the chat box. I'm going to start off by asking Dr. Phillips to share a little bit of his work at UNC. I know that he's been doing a lot of work alongside his adult colorectal colleagues, and so I was hoping maybe to hear a little bit about how you've synergized the work that you're doing on the pediatric side with the work that's being done in the adult colorectal world, where there are some more established and long-lasting protocols in place.
Sure. I think that's a great question. Initially, the adult colorectal surgeons at UNC had a pathway that they'd been using for a few years. They modify it here and there, depending on research that comes out. And when we developed our pathway, we found some differences that were specific to our pediatric population. And because referrals from the community come through whoever sort of their GI is managing the patient, some adolescents go to the adult colorectal surgeons. And so we've worked collaboratively to try to standardize our pathway between the two services, because so many of our partners are so important to implementing a successful pathway. So nursing, anesthesia, and when you have disparate pathways, it creates confusion. And so we've standardized medications so they're the same regardless of who the operative surgeon is, as well as utilize their expertise in pathway implementation and adherence. Review easier the system within the larger healthcare.
That's really great. For our team that worked on the heavy lift of the systematic review, I will ask, I'm always wondering about what the next big study that we need to do is as a field. And when I look at the different topics and different questions that you guys so diligently provide us with information on, I was wondering if maybe we could just go around the horn and have each of you kind of talk about the specific question and what you think the next best frontier is that we need to navigate. Elizabeth, you want to start us off?
Sure. So my question was regarding the laparoscopic versus open approach. And I know that more and more we're moving towards laparoscopy in many different fields. Unfortunately, this just hasn't been studied terribly well for pediatric patients, but it shows a lot of promise. And I think Rebecca can talk a little bit more about that with regards to the question that she did. It does seem that from the studies we saw, there still seems to be a longer operative time with laparoscopy, but that could be because of the small numbers of the studies, and also they could have been early in their learning curve. So I think this is an area that still requires more study.
And hey, I'll jump in next. So my question number 5, looked at specifically infertility. And there was a question in the chat earlier about that one of the participants was surprised at the wide range that was found, that was quoted for infertility. And a lot of the issues around infertility are that there's not long-term tracking and the cohorts are not identified appropriately, and they're extremely heterogeneous. They don't look at the operations the same. They don't look at the same cohort of children or adults. And then the definition of infertility, very dramatic, extremely strict criteria for reviewing any of the literature. There'd maybe be 1 or 2 applicable studies out of the 20 plus that we found. So I think the next direction would really be to track young adults, children, longer to see how their fertility and sexual function is measured, and then do that in a more standardized fashion.
Great, and I can follow along. My question was the second question on the optimal timing, and I think there was already some discussion earlier on the chat, and I appreciate Christy responding to some of the chat. The one question regarding the conversion rate to Crohn's, and I think the paper did clearly fit those were earlier, those were younger children, and so I think the message for some of what I looked at in this question was there's a lot of smaller studies, single institution studies that are answering these questions. And so larger cohorts, bigger studies will probably allow us to answer some of these questions better. The other part of that discussion really focused on biologics, which have started to change the way we manage these children. And I think that ties in with Jason's talk last year at the Tech Talk as well. And we still need some more data on the safety of using the biologics around there. But it does seem to appear that most of the biologics are safe in the perioperative period, although there can be some risks associated with the stoma retraction, or stoma dehiscence, especially with Entyvio. So I think from that question standpoint, larger group studies, bigger cohorts are probably needed as we move forward.
All right, and I'll give Alana the quick last word.
So I agree with all that. I think what we learned as a group from trying to answer these questions is that the data that is out there is really not fabulous. It's mostly retrospective single institution studies, mixture of adults and kids, no long-term follow-ups, no standardization. So I think this area is really ripe for us to band together and do some multi-institutional prospective data collection and try and really get answers to these questions. I think some of the things like fertility are going to require really long-term study, like the VA studies and the nurses' health studies that were done many years ago. And it's really up to us to band together and really get answers to these questions, because our patients are going to need the answers and we need to have the data.
Great. Well, thank you all.
Great. Welcome back, everyone. Thanks so much to the previous group for a great systematic review about IBD and ERAS. Thanks so much to everyone for participating today, and especially my co-hosts, Nathan from Detroit, Michigan, Tim from Houston, myself, Chicago. It's really been wonderful to be with them and to be with all of you. I'd also like to thank Casey Calkins for his leadership on the program committee for putting all of this together. And of course, Dr. Waldhausen for his presidential leadership in this most unusual year. We're going to hear from him in just a moment, but before we wrap up, we want to also remind everyone that the HUVA platform will be open to anybody who's registered for this event. And there's a lot of information in the chat and the questions with a lot of great links to articles, different other attendees of the meeting that you may want to connect with. So please feel free, and please keep using that. The APSisodes will also be coming up and will air starting May 26th on trauma, and that'll be through the same platform, and you'll be getting updates from APSA about those. So please stay tuned, stay engaged, and we look forward to seeing you all in person, we hope, soon. But for now, we'd like to turn this over to Dr. Waldhausen for the final wrap-up. Thanks. Bye.
Bye, everyone.